हेलो 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 हेलो
हेलो चेक वदारो हेलो चेक वदारो हेलो चेक वदारो हेलो चेक बस.
Loud. Everybody will hear me. No worries about that. Hello, everybody.
Okay.
So I have a few people presenting from US, but they will join us online.
Yeah,
And then we have as well some, one of them, I have to run the video.
Uh, so for today's morning first session from the Kambin Society, I would like to invite Dr. J.D. Tharadara, sir, to chair the session. Dr. Christian Morgenstern, all the way from Germany. Good morning, sir. Dr. Karthik Kailash, sir, if you may please, sir, join us as chairperson. And we are waiting for Dr. Alvaro Rolling. So the mic is yours, sir.
Yeah, good morning, everybody. And thank you, Dr. Abbasi, to reinventing again the Cambian triangle. Previously, we used the triangle for any intradiscal pathology, and now, thank you very much. We'll see now any advanced technology and treatment through this safe corridor. Thank you very much. Yeah, please carry on.
Okay, so let's start with the session, I think. Yeah, Dr. Abbasi is going to talk about the Transcambin Society. We go actually back quite a long time. Dr. Abbasi has been doing very similar stuff than many of us have been working on with the Camin's Triangle. So Camin's Triangle is a well, it's an anatomical option for doing many things like endoscopy. Dr. Sanjay Harhangi here is an expert, for example, in transforaminal endoscopy. I do a lot of fusions too, and he uses a very peculiar way of going through a Camin's triangle. So I'm very excited to hear what he's going to talk about, please.
Well, thank you very much, panel. Thank you very much for having me here. Now, my first talk, I'm not going to use the entire 10 minutes. I'm just going to talk about why do we need another society? Because we started the Cambin Society for a reason. I think, do you mind to share the screen if you can? Now, as Christian said, many people have been doing the transcambin approaches, transcambin endoscopy, transcambin fusion, and none of the things I'm telling you is going to be new. But the fact is that still, after so many years, we are the minority, and that I'm hoping to change. So this is a tribute as well to Dr. Parviz Kambin. And by the way, on top, you see the translation of the Latin, that is the motto of our society, that by power of many, by many I mean you, we are going to establish to promote advancement of art and science of the surgery, because surgery is exactly that. It's not an exact science. It's half art, half science. And we can together move this forward. Unfortunately, Dr. Kamin passed away a few years back. I talked to him, and he talked to me about his difficulty to establish the transcambin approach. He literally used the endoscope from one of his friends, urology friend, to identify the Cambin triangle for endoscopy. And he noted a lot of resistance in his time. We are talking about in 1980s and 70s and 80s. But finally, the approach was established, and this approach was actually picked up in Asia more than Europe or US. Society is getting older, and spine is number one reason for disability. So whatever we deal with is going to be dealt with. We have to deal with it more and more. As a matter of fact, I just want to convince you that we have to have a new tool in our arsenal. Doing surgery this way sometimes is necessary, but doing this surgery this way routinely is not going to be sustainable. And this is from Becker Spine. This is the data from US that over 1.6 million instrumented spinal fusions are performed just in the United States, and the rest of the world is catching up with us. Not all of them are obviously lumbar, but those numbers are increasing. We need to have a different, better tool to be able to deal with it. Even now, in the United States, more than 80% of these surgeries are done traditional way, and that has to change. Now, obviously, in US and anywhere else, everybody who makes the incision half an inch shorter, they call it MIS. So MIS is sometimes is used not justifiably, but this is the reality. Please look at the lower tab now. And again, this is United States. Less than 2 to 3% of the lumbar fusions are done in a surgical center setting. And there is a huge, vast number of people that the traditional surgery is not doable. Like I treat a lot of 80-year-old people with cardiac problem that they cannot go through 8-hour surgery. They beautifully can go through a 1-hour surgery. So what I'm trying to convince you, we need to move from this to this, where we can do more surgeries in a surgical center setting. And many cases that we could not do, we could do now. As a matter of fact, it's not a week or a month that I don't do multiple BMI 55, some of them in my surgery center. So this movement is already there. Our panel is a proof of that, that I'm not the only person doing that, but together we can establish that. This is the typical day of surgery for me. And I just want to convince you, being able to take care of that many patients, half of them elderly, is not specific to me. Everybody who joins us by following certain protocol is able to perform at the same level. The number of the people who need that are going to increase dramatically. By the time you're 70 years old, there's only 1 to 2% chance you don't have spine problem. Those people, many of them we can treat without surgery. Many of them, as a matter of fact, don't need fusion. But if they need a fusion and that number is increasing, we need to have additional tool. Now, I'm going to stop right here and then let Dr. Anjum talk about the anatomy and history of the Dr. Cambin. I hope I didn't use my entire 10 minutes, but we will come back. I will use that time later to give you more information. Thank you very much. Dr. Anjum has joined us. I'm very enthusiastic to introduce her here for the next talk. So this talk, I'm going to take it off. And that is, I think that is, right? Okay, here you are. Thank you.
Thank you, sir.
Here's the
Thank you, everyone. So first of all, thank you very much to Dr. Ajay Krishnan, sir, for nice organization. And thank you all of you to participate to our Cambin Society. Thank you very much for your support. So I would like to talk about a brief history about spinal fusion and evolution of transcambin approaches. I am Dr. Farhan Jum. I am doing my neurosurgery resident in Germany, and also I am working as a Chief Executive Medical Officer in Cambin Society to support our society. There is a little bit history about Dr. Parviz Cambin. He's a pioneer of minimal invasive spine surgery. He born in Tehran in 1931. He finished his graduate from Tehran University. After that, he finished his orthopedic training in United States, and he became the professor of orthopedics. And he actually he bring the new touch to the Cambian triangle actually, and he bring it to the minimize tissue damage and reduce the recovery times. So actually, his legacy is continues through the Cambian Society, and he promote the minimal invasive spinal techniques. So how Professor Abbasi also said that he just passed away in March 2020, but his novelty and mission in minimal invasive spine surgery is moving forward. What are mission of our society? The Cambian Society is dedicated to advancing the global standard of spinal care by fostering open dialogue on complex cases, sharing insights from failures and success, and promoting collaboration across discipline. Through continuous education and mentorship, we are committed to training the next generation of hybrid spine, orthopedic, and neurosurgeons to ensure optimal patient outcomes. Our mission statement is to build a global community where spine specialists openly exchange knowledge, innovate surgical techniques, and embrace a multidisciplinary approach to shape the future of spine care by cultivating a culture of learning, collaboration, and mentorship, preparing the next generation of hybrid surgeons to lead the excellence. Here is this diagrammatic view of the Cambian triangle, what we are using. So this is the exiting nerve root, and this is the transversing nerve root from here. And we are using this triangle, and it is the superior articular process of the lumbar spine. And this is the transverse process. So this existing nerve and the superior articular process is making this triangle. So there is a difference between Cambian's approach and subpedicular approach. Sorry. So Cambian approach is a little bit, it's not close to the nerve. It is a little bit away. And subpedicular approach, what we are actually using for transforaminal epidural steroid injection, and it should be also close to the nerve. So that is the difference between the Cambian approach and the subpedicular approach. Here is another diagrammatical view of the Cambian triangle, that why it is actually safe, what makes it safe. So here is the pedicle, here is the spinal cord, and we are using the existing nerve root, the down part. So this triangle is actually safe. It is neither affecting the spinal cord, neither the pedicle, or neither the nerve root. This is an excellent picture to describe that the nerve root and the ganglions are just below the pedicle and are attached to it. And they move up once when we increase the size of Cambian triangle, and it's according to the need. This is also very nice picture to have a difference between what is the difference of T-leaf and what is the difference of O-leaf. So in T-leaf, we put the nerve root and the thecal sac at rigs, because when we touch that, so we are touching the thecal sac. But in O-leaf, we are only passes the nerve root and not the thecal sac. So it is not actually touching or damaging the thecal sac. So that's a historical evolution, that how it comes up to this. Now we are in minimal invasive and also endoscopic approaches. So it's begin actually from 1934, when it was for disc herniation, we were using the mixture and the bars. And then 1944 to 1980, that was P-leaf, is the posterior lumbar interbody fusion. After that, it's become a little bit modified between 180 to 82. After it comes to transforaminal approach, and after 1990, it is minimal invasive lumbar spine, and we are now ahead to the minimal invasive T-leaf. So here, this picture will demonstrate that what are the approach and what are the timeline actually it is started. That we started with A-leaf, and then it's P-leaf, then it's become transverse, it's like 1982, and then we come to T-leaf, X-leaf, and now we are in O-leaf, and ATP is anterior to psoas muscle. And this is very interesting picture because that will show that where we are in minimal invasive D-leaf, and it is actually the porn lateral. And we all know this is A-leaf, and this is P-leaf, and this is our T-leaf approaches. So actually, O-leaf is combining the minimal invasive and also the lateral approaches. That is also a very interesting picture to have knowledge about what is the difference between O-leaf and minimal invasive D-leaf. So in D-leaf, we are using the existing nerve root. And in O-leaf, actually, we are also keep it lateral. And then we are using the pedicle. So that makes the O-leaf triangle. And it is the superior articular process. And here is actually, we are using the existing nerve root, and that is the D-leaf approach. This is also a very good glimpse about that which approach is covering most of our spine. Like the O-leaf actually is taking the most of the places, like the thoracic 5 to sacral 1. Whereas minimal invasive T-leaf is only lumbar and sacral. It's L1 to S1. And these are the difference one can see. So this is a very good chart actually to have a glimpse about that where and which approach is actually beneficial for us. So with that, thank you very much for your patience. And I would like to ask Dr. Hamid Abbasi to come to the stage and continue. Thank you very much.
Good job. So again, thank you very much for this opportunity. I have given literally this talk over 250 times. So I can close my eyes and just recite this. But I'm going to cut certain part of the talk short because at the end of the Cambion Society section, I'm going to run an actual surgery from the beginning to the end, from the skin cut to the last stitch. Believe it or not, that surgery is 25 minutes for one level fusion. We are going to watch it together. So if I don't describe the technical part, please bear with me because we are going to cover the technical part just at the end of this meeting. And I have 9 minutes before Dr. Hazem Nicola is going to come with us. We talked about the spine is #1 reason for disability. The number of the people that need the surgery is just going to increase because society is getting older. The spine is a public health issue, no matter where in the world you are. You can help your parent in the last 10 years of their life because they cannot walk, or you can keep them independent. And that is our goal, is have to be in the next 20, 50 years to make elderly people independent toward the end of their lives. Regular surgeries, traditional surgeries are not able to do that. And it's not about the skin incision, it's about what happens under the skin. All those muscles that you don't cut help the patient to recover faster. It's about that we are not disrupting the practically autoregulation of the muscle. By cutting the tendon that we don't reconnect, we practically putting the patient on a path of failure. And as well, the vascularization of the bone, we all know there is not an artery of L5 or L4. The vascularization of the bone is through surrounding muscles. So posterior approaches practically devascularize the vast majority of the vertebral body. As a matter of fact, these studies from 1930s. When you do go to lateral gutters, so when we do a traditional TLIF, you're reducing the vascularization of the bone to the 25% of the original value. All muscle sparing approaches, not only transcambin OLIF or KLIF or whatever you want to call it, all of them, they have higher rate of fusion exactly because of that, because you're not devascularizing the bone. Now, this is a very important picture that I share it often. This is a patient I did a two-level two-level TLIF in 2012. In 2014, I did adjacent segment surgery. And for all spine surgeons, we should understand, this is a vascular scar 6 months after our TLIF. This is how it looked like. And after 2 years of OLIF, this patient had an accident. I had to take the patient back to surgery. And it's practically pristine tissue. No surprise that this patient will recover faster. This is how scar look like compared to regular muscle. And look at that. This is a patient of mine. I did a 4-5 fusion. 2 levels above it, the multifidus muscle is scar. Now, our study is running, or over 1,000 patient studies running. The result probably going to show that we have less adjacent segment disease, but I can tell you once I have published my paper. This is a study based on 380,000 cases. Every additional half an hour on the anesthesia adds 17% to the combined risk of the surgery. Let me repeat that. Every additional half an hour on the anesthesia, independent from what you do, adds 17% to the combined risk of the surgery. Surgeries that are 2 hours are twice as risky than surgeries that are below 2 hours. Now, why is it important? Because by bypassing all the approach steps like cutting, stopping the bleeding, cutting the bone, and so on, you literally saving time and saving on complication. I was so privileged to be in Chennai, and we did 3 cases together. Literally, in the first 10 to 15 minutes, our cage was in. That's it. And it's not because we are cutting corners. It's not because we are trying to be fast. It's because we don't have to do all the steps that you need to do to be there where the actual pathology is. So I'm going to show you here, when I talk about OLIF, I'm actually talking about multiple procedures that we combine to OLIF, because you use the same approach, same position, same instrumentation. So I'm going to interchangeably talk about OLIF, MIS, DLIF, which is a prone lateral, which we have been doing. We published our paper in 2017. And that enabled you to help more patients. Sometimes the transcambin approach is not available. Now, I'm going to tell you that as of last week, I have done 1,665 cases, over 3,400 levels. So we have enough experience. I have all the complications you can think of, but I have as well backup plan. I have, this is a teachable procedure, but it has to be taught in a structured way. Unfortunately, I can't tell you about United States. We finish our residency. When there's a new way of learning something, we go to Vegas, we do 4 hours of lab, 8 of our gambling, come back and try to do that, and we learn as we go. This cannot be done that way. You need for this, you need to have a structured way of learning it and teaching it, and that's what I'm hoping to achieve with the Cambin Society. So I the time is now, I have a few more minutes before Dr. Hazem can talk about the deformity collection. So this is our statistic. And again, if you haven't seen the surgery, it's hard to wrap your head around that you multiple level fusion under 1 hour. But once you look at it, once you follow up the steps, this is a doable, teachable, learnable skill. And I just want to emphasize again and again, you don't need to have superior surgical skills to do that. Everybody can be a pilot. Piloting is a hard thing. Everything you do is hard. You are at top of your profession. So these are teachable skills, learnable, you can learn it. You just have to learn it in a structured way. This is a 2-level ALIF in the same hospital where 45 minutes of that is actually the anesthesia time. The rest is actual surgery. They do anterior, then they break the scrub and the sterile field, then turn the patient to posterior. But at the same time, the surgical time were under 1 hour. And I can guarantee you other people perform at the same level. I want to share with you maybe 2 more slides, and then we go to Dr. Hazem. This is in one hospital, 390 cases, 5 surgeons performed TLIF. And as you see, as expected, with higher BMI, the time of the surgery goes up. Now, I can guarantee you, and there is a good evidence of that, and that's proven, that with the higher time of the surgery, that directly correlates with the complication rate. The need for transfusion, infection, hospital stay, it correlates directly. As a matter of fact, after 3 hours, it goes up, even the angle is higher. And this is the MIS TLIF in the hand of a star MIS TLIF patient. So if you are good at MIS TLIF, you have some benefit there, but at BMI of 37, you don't really gaining much, at least not according to this study. But again, this doctor is a star MIS TLIF surgeon. By the way, Dr. Farha, this is the doctor you and I talked about yesterday. He is fantastic and that, but it's the physics is physics. You have to go deeper hole, and at BMI 37, now look at that. Olif, transcamin Olif stays flat. This is a different study to confirm that data. Our patient ambulate 96% of them within the first 24 hours. Every week, I do 2-3 level spinal fusion in my surgery center on people who have BMI above 50, and I discharge them within hours after surgery. I put thousands of those testimonials online because I could not believe that that can be done. So I love that choice.
Yeah, extend 5 minutes, please.
So I'm going to stop here. We are going to talk about the actual technique later. So, but maybe I have time for one question. If anybody has a question, I can answer one question. Otherwise, Dr. Hazem, I'm hoping, is online and ready to go. Let's see here. Let's see.
Okay, thank you for your wonderful lecture. I'm Dr. Tanaka from Japan. Nice to meet you again. So, I'm a big fan of simultaneous single lateral ATP. So, you said from transcumbing triangle, it's a very narrow corridor. If you use lateral corridor, there is a big corridor, and we can do simultaneous in a single position, and also we can use navigation, very safe. Why you choose this a little bit risky surgery?
You're talking about that there are other approaches. Why do I use this risky procedure? Is that the question?
Yes.
Okay, well, this is a tool in your toolbox. Now, there are multiple paths to the spine. For you, the best path to the spine is the one that is safest in your hand based on the pathology that you do. So this does not replace ALIF or laterals or OLIF ATP or TLIF. But what I'm advocating is that in 2024, this needs to be part of your toolkit.
Okay.
Now, it has a risk profile like any other surgeries. This is, we won't be having time today to talk about that, but I love to catch up with you. And I do give those talks about comparing when is a good time to do this surgery versus other surgery. In many cases, you're right, this surgery might be more risky. In other situations, other surgeries are more risky once you balance risk versus benefit.
Is it okay for you just take it's just an option? It's not the best option, right?
No, it is one option
Okay.
in your toolkit. It's one tool in your toolkit, but in 2024, you need to have that tool, add that to your toolkit. Okay. So I don't see Dr. Hazem online, but I do see Dr. Scholl Kim online. Dr. Scholl, do you mind to give your talk now?
That sounds good to me.
Hazem, please. So this is my absolute pleasure to introduce a legend in the endoscopy, Dr. Scholl Kim. He is almost like a celebrity, not almost, he's a celebrity in the United States. He's a good friend of mine. We have a full crew here, Dr. Kim. Let me see if the audio works, but then I will pass the presentation to you. And let's see if we can manage the sound for Dr. Kim.
Wonderful.
Kim,
Can you all hear me?
I see you talking, but your voice is still not heard here. So let's see if the technical
now?
team can correct that.
How about now? Can you hear me at all?
We're still
No?
working on the technical part.
I should probably try to say something.
Here you are. Here you are.
Wonderful. Well,
So-
thank you very much for that introduction, Hamid. I hope everyone knows that Dr. Abbasi is the hardest working spine surgeon in America. He does everything. So thank you very much for having me. Can somebody let me know that the slides are up in case I can't see it on the Zoom screen? How is that?
Yeah, slides are being seen.
Great, and you can hear me. Thank you so much. So Dr. Abbasi asked me to talk about the transcambent and endoscopic spine surgery. In listening in, it sounds like many of you are already doing this, but so forgive me if I am a little too basic. And to start, just want to disclose some of my potential conflicts of interest. I am a consultant, and I've helped a variety of different spine companies develop their minimally invasive systems, et cetera. Especially Eloquence, and the endoscopic system that you're going to see is from them. But I will try to be very objective. And I think everyone knows the importance of this gentleman, Parvis Kambin, who described this anatomic kind of hidden secret door to a treasure trove of new ways to take care of patients. And basically, what is it? We call it LESS, lumbar endoscopic spine surgery, which you have to admit is a very cool name for a minimally invasive procedure. So this is like essentially what is it? It is what I call the oldest state-of-the-art procedure that we have, because it has been around for a long time. And I think this picture just immediately tells you what the procedure is. It's through Kambin's triangle, getting at the disc, and you can see the cannula is right where you need it to be because most disc herniations are there. And Dr. Kambin's group did a lot of work, including the publication of a very good randomized controlled trial that was published in 1999. That is 25 years ago. And this work was probably done 5 years before that. So this is not a new technique. Since then, a number of other giants in the field have led the way. They trained kind of like the second wave of people. And please forgive me if I'm missing somebody because this list is not complete And for any of you that can think of somebody else that needs to be on either one of these pictures, let me know so I can add them. But since then, if you look at the amount of work that was done just by simply asking how many publications in endoscopic spine surgery are there? Just in PubMed, this is it. And this is old too, by the way. The number is tremendous, over 5,000 studies. Now compare that with XLIF, MIST-LIF, and microdiscectomy. There are more studies in endoscopic spine surgery than those 3 other new surgeries combined. And because of that, there are more than 1 systematic reviews, and there's at least 2, probably 3 now, meta-analyses. That's when you know you have plenty of publications because people can just start pooling the data. And these are the numbers that are important. And pretty much all these studies say the same thing. So the first question about does transcambin approach for endoscopic surgery of the spine work? This is not a question anymore. The answer is yes. There's better data on this surgery than any of the other minimally invasive surgeries that we do. So that is not really the question, although you would think it is based on like the PR that we have in at least the US and probably throughout many areas of the world where people still think maybe this works or doesn't work. And that's probably the more important question. If I keep saying endoscopy is so great, why is the history of its adoption so terrible? Why is it that even after 30 years, we're just the minority of the spine surgeons? So I'm the only real dedicated endoscopic spine surgeon in San Diego that does transforaminal endoscopic surgery. I do interlaminar and other things, but that's the original. I'm pretty much the only one. There's a few people that do it intermittently, but I do it routinely, and I almost never do a microdiscectomy. So why is that? There's probably 2 main reasons. The first has to do with reimbursement. That's an idiosyncrasy of the crazy healthcare environment that we live in America. So hopefully this doesn't apply to you, but luckily that's changing. The more important thing, I think, and probably the more kind of important thing to address is the learning curve. And I think everyone knows that the learning curve is not great. I did a kind of a review, a systematic review of the learning curve. And for endoscopic surgery, it's anywhere from 35 to 72 cases of a learning curve. That's crazy. That's way too many. You can't do 35 cases and screw them all up until you get good at it or have a terrible record. That's why it's not being adopted, because it's too difficult to get started, because the competing surgery is a microdiscectomy usually, and that is pretty much one of the best operations that we do. So it's really hard to go from a great operation that you're very comfortable with and then struggling through a very technically difficult surgery with lots of initial complications. So we always talk about this. The learning curve is difficult, but we seldom ask the next question, why is the learning curve so difficult? And then we never ask, how can we make it better? I think that's changing. And I think everyone realizes there's a lot of work to do. And I can go on and talk about some of the insights on this, but I think that's a topic of a separate discussion. But suffice it to say that the key elements are that we need situations like this where groups of people get together and address this problem in a concerted effort, in a scientific way, because it's not a one-person kind of effort. Also, I don't know if you've noticed, but the instrumentation has not changed very much in 25 years. And it would be like me using my iPhone 8 when I have an iPhone 14. Yes, the iPhone 8 works, but this blows it out of the water. So we need to have a concerted effort to try to push the endoscopic companies to work on improving instrumentation. They have a hard time because it's not a big money item in America. So less amount of money in the pool, less amount of money for research and development. But we have to keep pushing on this. And then, like anything that is difficult, Dr. Abbasi said it, it's like, flying a plane. You have to learn how to do it and you have to practice. And you should not fly by yourself until you have a certain number of training. It can't be over the weekend. So for right now, If there's one thing you should do is find a mentor that you know and trust that does the surgery a lot and pays attention to the outcomes of their patients. See how they do it exactly start to finish and do it exactly the same way until you get good at it to the point where you can start making modifications. And probably the OLIF technique is the similar way. If you do it exactly the way Dr. Abbasi does it, it's probably unbelievably fast and unbelievably safe and efficient. So with that, I thank you very much. Oh, I left out one thing. The last thing is the mentorship. And I think that goes along with finding that surgeon that you know and trust, and that it's not just a one-time event when you go learn. When you go home, the interactions continue. So it is a journey and a process. And I think mentorship is the last thing that we really need to focus on, and almost needs to be one-on-one. So with that, thank you very, very much for having me.
Thank you, Scholl. This is truly always a pleasure listening to you. Every time I listen to you, I learn two more things. And I think the mentorship is the most important part of it. And learning it in a structured way is, I think, what we have been missing, and hence Cambian Society. And I'm so thankful to be here exactly because of that. So I'm going to actually run a, for people who don't know, it is pretty late in United States, but it's in the middle of the night in Europe, and Dr. Gasco is in Spain right now. So I like to run his a video about his talk about using the transcameral approach, OLIF approach, for high-grade spondylolisthesis, because that is the next level. What I'm really proud of showing you this video is that it took me 500 to 600 cases before I started doing high-grade spondylolisthesis. Dr. Gasco did it after 60 cases. So, and that is the approach of what Dr. Scholl Kim was talking about, that structured learning, mentorship. They don't have to, the next generation doesn't have to make every experience, every practically learning curve start from scratch. They can add to our learning curve. So with no further ado, I'm going to just run the video of Dr. Gasco exactly talking about this. So this is still uploading it, but it's going to be running pretty shortly, and just I'll be standing here silently, making sure that video runs properly. No, please don't install, not now. Let's see here. And this comes with the actually with the sound. Is it possible for you to use the sound of this, please? This actually, I can go back, and if you can use the sound of this. Oh, I think that in this computer is back here.
Ah, एक मिनट
Thank you.
होगा
Yeah, it's all the way in.
ना
So I can go start it from scratch.
audio
Oh, I see it is silence here. May I just, I think I found it here. It's silence here.
It says neuroscience, neurosurgery. Today I'm gonna talk
Some technical.
very nuanced procedure.
Okay.
I work out.
Thank you very much. So I would love to ask Dr. Varun Agrawal now to come and give his talk. But while we are setting this talk for Dr. Agrawal, which I believe is going to be on your system, while we are going through that, I want to emphasize a few things. I just had to help Dr. Gasco with 12 cases. 12 cases is not a extended kind of situation. As a matter of fact, I was really privileged to be in Chennai. After we did 2 cases, and after the 3rd case, the resident, the fellows, they were on top of it. They grasped it like a sponge, and they were really good at it. But there are lots of mistakes you can do in the learning curve. That's what you need to avoid. Yeah. Another thing that I think is important is that you have to patient. We are in the phase as well that we have to prove this is a good surgery. So we have to gather our data, and we have the database. So if you join us, please join us, put your data in. We do that learning curve, a kind of statistic for you. So thank you so much for all this. By the way, Dr. Varun Agrawal is the co-chair of the Cambion Society, so it's my pleasure.
I think with the end of the session.
Thank you, Dr.
Yeah, it's
Abbasi.
okay, yeah.
Thank you so much for the introduction and MISSABCON for having me here. So I'll be talking about the transcambin fusion. Can we have the slide, please? So how to do the surgery under GA and how to do it under local anesthesia. So these are the routine cases which we see. You can see the list is there. And these are the routine cases which we get in our OPD. And like Dr. Farah pointed out, there are so many lifts to choose from. And today we'll be talking about the transcambin approach. And on the disclaimer side, I do all my cases under local anesthesia. So I'll be talking about local anesthesia a bit more. And then in the end, I'll be taking up the GA. So how to proceed under local anesthesia? So this is the protocol I follow. So the preparation for the patient starts in the pre-operative room itself. So we do the pre-operative medications 5 to 10 minutes before we shift the patient to the OR, so that by the time the patient is taken to the OR, the drugs start taking effect. And we spend less time in patient fidgeting inside the operating room. We give a painkiller, diclofenac, pantoprazole, tramadol, ondansetron. All this is given in the pre-operative room itself. Foley's catheterization, ECG stickers, even the cautery pad, everything is applied in the pre-operative room. The wide bore cannulas in the IV line, everything is secured. And if I have to do it under epidural, for some cases, for some patients who are a little scared and with the time I'm started using epidural less and less. So I even plan to do it 1 day before. So we don't waste any time in the OR. So sensitivity testing, explaining the patient, the procedure to the patient, everything is done in the pre-operative room itself. And then during the surgery, the patient is made prone, head placed over the ring. The routine way which you position the patient prone for any spine surgery. The trick is to make the patient very, very comfortable. Everything, a awake patient has to be made very comfortable during the surgery. All the bony prominences have to be padded, gel foams, etc. have to be used. The operating room temperature has to be, the patient should not be uncomfortable because of the temperature. We use patient warmers, etc. All that is used, and this is a small video I'll show. So as you can see, everything is very well padded. The patient warming is placed, the curtain is placed, even a patient face is not covered too much, because a patient starts panicking if their eyes is closed and they are not very comfortable. So all this is done, everything is doubly checked by me. And if I'm placing the epidural line, I just snip off the tegaderm so that I have some space for my screws and we can make it a sterile preparation. I secure the arms and the hands, everything is secured, but not very tightly. So patient is not uncomfortable, but they have a little margin of movement. And the feet of the patient are exposed so that I can, ask them during the surgery that to show me the movements of the feet, because I'm doing this procedure under local anesthesia. So as you can see, the abdomen is completely free because I'm using a Jackson table. You can use bolsters as well. And notice here, because of the obesity, the X-rays of poor quality. So this is how we tape the patient to mobilize all the fat and the all those abdominal fat, etc., away from the site of operation so that we can get a better C-arm picture. So this is just taping the abdominal fat and then just taking it out of the way. And you can see the picture has much improved and you can do a better X-ray. So this is the electrical warmer which I use, again, to make the patient really comfortable during the surgery. We can do it under single C-arm. Pre-operative C-arm image of the operative level is taken, and we should, since it is basically a C-arm based procedure, your everything should be very clear. Your C-arm image should be very clear before proceeding for the surgery. And we also put notes over the C-arm so that if I'm using a single C-arm, the technician doesn't have to, bother too much and reduce the radiation exposure to me during the surgery. So we write the values of the EP and the lateral. The position is marked on the floor as well as on the arm, what position is needed. And now, as Dr. Abbasi has introduced me to dual C-arm, I've now started using the two C-arms, which is available in my setup. So this is how we set up the patient with a dual C-arm position, one in the lateral and one in the AP. And as you can see, there is a big corridor for the surgeon. And if I can stand, everybody else can stand. So I don't think that is a problem. This is a common question people keep asking, where is the position to operate? And this is the anesthesia protocol, which I use during the local surgery, local infiltration of 5 ml lignocaine with adrenaline 2%, 10 ml sensoricane and 5 ml NS. And this is for the transcambin, where it gives a sensory blockade and doesn't give a motor blockade. The dexmedetomidine infusion, because it gives a sedation as well, decreases the heart rate and blood pressure. And IV fentanyl 50 micrograms when needed, when the really painful part of the procedure is anticipated. 2-3 minutes before, I would tell the anesthetist, just push in the 50 mics of fentanyl. A low dose of midas just as an anxiolytic and not as a sedative agent. And if there is high blood pressure, we can use a nitroglycerin infusion. And in the initial cases, I used to use epidural again in the sensory dose, but now with experience, I'm using less and less. And this is just the instrumentation set. And as you can see, with just a very small inventory, we can do this procedure. So this is the case, 40-year-old female with pain in the back. And you can see the listhesis there. And this is the MRI picture. This is the positioning of the patient under C-arm. And this is, as you can see, local anesthetic is being given and the standard transcambin trajectory. The dilator is inserted, the working channel is inserted, and you can see the patient is quite awake and comfortable. And we can just put our big instruments through the channel directly. And even without the endoscope visualization, we can do adequate disc preparation, sizing of the disc. And this is the trial now, which is being put. So as you can see, the patient again is under local anesthesia. The graft from the PSIS, again with a power drill in the local anesthesia. And then we pack in the graft outside of the cage. And then finally the guide wire, and then the cage is put over the guide wire in the transcambin approach. And then local infiltration for the screws. The Jamshedi needle, everything is done under local anesthesia and patient is quite comfortable. You can see she can move. And the guide wires is placed, even the rod, everything is done under local anesthesia. So this is where the advantage I feel personally for this procedure, where the patient is quite comfortable. And even for those patients who have a high risk for general anesthesia and post-operative ICU, can have a safe spine surgery without putting them under undue risk, especially for the elderly. And then I started asking the question that if I'm doing this procedure for the high risk cases, then why can't I do it for the low risk cases as well? So the basic advantage I feel is doing the procedure under local anesthesia for me. And the awake patient is acting as a neuromonitoring for themselves. So all this is done. Again, this is the routine system for minimally invasive screw placement. And as you can see, even the routine system works very well. And then we'll infiltrate the path of the rod placement again with the local anesthesia. So this is the infiltration, and again, the rod is again placed under local anesthesia. So finally, the screws are tightened. So this is the final construct, and you can see it is very well reduced and very well the disc space has been jacked up, the foramen has been opened. So this is the final construct in the AP view. These are the scars. I placed transverse screw incisions because they are more cosmetic to the patient, the rod insertion scars, the cage incision, and the bone graft incision. So this is the immediate post-op picture, and in a couple of hours, the patient can be made ambulatory. So this is where the advantage of this surgery lies. We don't need to put the patient into post-op recovery or ICU or anything. As tolerated, we mobilize this patient as soon as they can tolerate. So if we are doing this procedure under GA, we need to use neuromonitoring. And this is a special probe where it has a sleeve which goes over the probe. You place the neuromonitoring probe through the incision, approach the neural foramen like you do with the needle. Don't advance it beyond the medial pedicle line. Stimulate the nerve. So stimulate it at 3 milliamperes, and when in place, go up to 4 milliampere. So if there is a positive signal at 3 milliampere, you are within 2 to 3 millimeter of the nerve, and likelihood of nerve injury may be up to 40%. But if there is no signal up to 4 milliamperes, you are more than 5 millimeter away from the nerve, and the chances of injury is less than 5% at L1 to L5 level, and less than 8% at L5S1 level. In vast majority, you may just have nerve irritation, which is transient, and risk of nerve injury is less than 0.3%. Minor numbness is seen in 1 to 2%. And personally, I feel these things mostly happen in the GA cases, because in the awake patient, they don't let you be too adventurous and be too near to the nerve. And then finally, you advance the guide wire through that channel which you have placed, and then the procedure is the same. So this is just a post-operative protocol. So the take-home message is that transcambin fusion is safe, effective, and efficient. Careful patient selection and thorough knowledge of the procedure is mandatory. Use of local anesthesia or general anesthesia depends upon the surgeon's preference and expertise. And if the indirect decompression can work from the front, like we do it in OLF regularly, it can surely work from the back as well. And you always have an option of using the endoscope. If you feel a direct decompression is necessary, you can do it in the same sitting or maybe stage the procedure like we are doing it in the OLF. So this is the Cambin Society, and I invite everyone to be a part of it, and we can take this procedure to more people. So thanks a lot for a patient hearing. So if there are any questions.
Couldn't be more thankful for you. What you do is magic.
Thank you so much.
And I think the magic what you do is put the right team together and the right patient, and how you prepare them for this procedure. My question is that, yes, please. Sorry, I'm just saying that, the magic of what Varun is doing, putting the right team, including the right anesthesia, right people in the war, and preparing them for this. I can just tell you, in my system, I have to manage the nurses in the war more than the patient if I was going to do this. The right team is the magic of this. But my question for you is, what percentage of the patient you think you are qualifying for OLF do you think you can do in awake?
So absolutely, sir. Doing the surgery in a local anesthesia is a learning curve both for the surgeon and for the team, and everybody have to, grow together. Because for an awake patient, you can't spend too much time and in a time wastage in experimenting on the table. So that will come subsequently in your learning curve. With time, I've started finding that rarely there is a patient I need to put under GA for this procedure in particular. Because for me, in my hands, the entire advantage of this procedure is that I'm able to do this under local anesthesia for a patient who have been refused surgery because of so many risk factors by a lot of people. So if we are able to do it in those category of patients, we are able to help them, and we can send them back home safely and fast. So this is a true outpatient surgery in my books. So this is where the advantage lies. So I had one of the patient, I operated and I had to leave the city for a conference, and said, you can go home by evening. So that patient said, I will not go home. He was so comfortable. I said, you can go home. There's no need for you to get admitted. He said, if I go home, my daughter-in-law will say that you have not been operated, she will not take care of me. So these are the kind of responses I've been hearing from the patient. It is so convenient, even for the surgeon. I can do all these lifts, but still now my workhouse has become this transcambin because I can go home faster. This is just a 20-30 minute job, provided you select the right patient who doesn't need a direct decompression.
Okay, we have two questions quickly.
Okay.
Yeah, please.
Dr. Tanaka from Japan. Thank you for your presentation. So
Yeah.
I didn't know that Indian patients are so patient. In Japan, the anesthesiologists don't allow this kind of surgery because it's very risky. Open conversion in a prone position, it's convert general anesthesia in prone position is very difficult. So if the patient has severe pain and you would like to change the local anesthesia to general anesthesia, anesthesiologist allowed to this kind of surgery?
Yeah.
So there is some possibility.
Yeah. So I've been hearing Dr. Masato say that this is a risky procedure. So I would ask you, doing an O-lift or a T-lift in a patient who is respiratorily compromised, has a triple vessel cardiac disease, which is more risky? Doing it under GA in that kind of a patient who is a liver failure, who has, diabetes through the roof. So all these kind of,
Varun.
that is one thing. The other thing being that
Varun, sorry to interrupt you. Actually,
Final anesthesia you can use.
sorry, what he want to say, in a prone position, convert to local to GA is quite difficult.
Question.
So I will to cut short, I say, okay, it is a lateral position under local anesthesia if you are doing, and if require general anesthesia, we convert it is easy, but in prone position is difficult.
Why do you want to convert it
No,
under?
it can happen, even local anesthesia can create problem.
No, that's
So,
what I'm saying. You change the if you are doing the surgery, you have done the sensitivity testing, everything is there. So local anesthesia per se is not going to do a problem. If the patient is not tolerating, you stop the surgery, take him on in a supine position, incubate and do a routine.
Another two aspect, if you continuation of this one, total dose of local anesthesia of doing this surgery, that should be kept on mind.
Yeah.
Even vitals, patient under general anesthesia, patient under local anesthesia, conscious autonomous system may make lot of difference in the vitals, parameter, pulse and everything. So that require even further study. Anyway, sorry for time restriction.
Yeah,
One question, yeah, please.
Dr. Sudhir from Chennai. That was a nice presentation, Varun. My question is, see, even under local or epidural, the moment we touch the end plates, when we scrap it, okay, the patients, they shout in pain, even under epidural or local. See, the major challenge, I would not call it as disadvantage, I would call it as the challenge with the transcambin approach. We have been doing a couple of cases under local as well. When the annulus and when you touch the end plate, if you want to prepare a very good end plate, in our experience, we feel that it's not up to the mark if the patient is under local. What is your take on that?
Yeah.
And I have another question. I'll wait for this answer.
So I've been doing these cases under local anesthesia for a good part of 4 years now. The only part that pains is the periosteum and the annulus. Once you are inside, scraping, doing everything is not really painful.
Do you inject LA when you remove
I've never ever have the need to inject it in the end plate.
Even
or
when you
anything.
scrape the cartilage?
Patients are super comfortable.
Okay.
We are scraping the end plate. We are preparing the end plate. So this presentation was for GA versus LA.
Yeah.
For my routine presentation, which is on the day 4, you will see the cases where I have done up to 3 levels of fusion, again under local anesthesia with post-operative CTs showing fusion. So fusion has never been a challenge, like Dr. Abbasi said, because of the preserved blood supply and everything. And if the patient is actually shouting, I cannot do that surgery. I don't have to prove anything by, doing that. It's a local procedure with the patient being super uncomfortable. So that is why I made this video with the patient's face, showing each part of the procedure, patient is quite comfortable.
And,
so that
It's
is never a problem.
Another short question, just a minute. Regarding the same, just an extension of this. Suppose if you are advising the crowd here to do transcambin, what would you suggest? I think should they go through the GA first and then get to do this surgery under local, or can they start under local? Because again, doing under GA, you know, in our country, it's a challenge to use neuromonitoring for each and every region case because of the affordability issue.
Yeah. So I would put it the other way. Instead of starting under GA and then transitioning on to local anesthesia surgery, I would say start local anesthesia endoscopy first, because at least you get used to the transcambin approach in a much safer way. I've been doing transcambin endoscopy surgery for a better part of 7-8 years now. And this has been my evolution to the fusion. So doing it under GA, personally, I feel is a lot more challenging unless you are using neuromonitoring. And to answer Sir's question of using local anesthesia and the dose, so we are not giving local anesthesia in a bulk dose at the same time. So we give it at 4 places for the screws. By the time we have placed the Jamshedi and come back, the metabolism of this local anesthetic has also started. So it is not giving the entire 50 ml or 100 ml at once and intoxicating the patient with local anesthetic. So everything is part of that learning curve and how to go about it. It is a complete procedure in itself.
Thank you. It's just a very short comment because we're short on time. If you guys are interested in what we call awake surgery, which is using this kind of local anesthesia, on Saturday we have a session on that using blocks. Okay, but I think the problem to the doctor in Japan, the problem is not the pain. The problem is if you get respiratory problems. It's what do? Do you flip the patient? Do you don't? And well, you keep saying it's a risky procedure. I don't think it's a risky procedure. You can do this even for XLIFs and and single position surgeons. But we do awake surgery or local anesthesia surgery for endoscopic patients all the time. What do you do, Sanjay, when you have a respiratory problem?
Well, at our center, then we use a laryngeal mask, and the patient is ventilated, and you have your anatomy at vision at that time, probably. So that's not a problem for prone position. They just put it the laryngeal mask.
Thank you, Dr. Varun. Yeah, please.
I use the cheapest thing. I just put nasal prongs, nothing else.
Before you go, please come over here, because I couldn't be more proud of you as a co-chair of the Campus Society. And I personally can learn a lot from. In that sense, I was thinking what to bring you as a present. But what I'm bringing you is so-called the decode state. So you can make the production more efficient. So this is for you, and I'm hoping that nobody comes to speak better than you can. Thank you. Thank you. So the last section, and I'm not going to use it entire time, so I promise you we will be on time. Can we please change it to this again? I'm going to show you entire whole procedure. Is there a way I can walk? If I walk here, do you hear me all right? Hear me all right? I will be loud because I want to even stronger. Everybody hear me? Wow, this is loud. Give it to me here. Thank you. So, as you see, you're going to see the entire OLIF procedure from the beginning to the end. And you saw the 2 C-arm technique. You cannot do this surgery this way with 1 C-arm. You can do it with 1 C-arm, but you lose most of the benefit of efficiency. As Varun showed rightfully, the space is just right for 1 surgeon, but that's all you need. Your assistant, as you see, is on this side, and she's a very experienced assistant. Let me see if I can activate. Yep, here it is. And practically, what you see here, I put the first K-wire. You see the neuromonitoring, and on top here, you see, for some reason, this is not really working, the laser here. Okay, let me see. Oh, this is not the laser. That's why it's not working. So here you see the tools are used. Here you see actually the AP and lateral picture. Here you see the neuromonitoring. And I always use neuromonitoring. This is not a procedure you can do without neuromonitoring. This is your eyes. And in United States, half of the people, half of the spine surgeons use neuromonitoring, half of them don't. Your choice, but not for this procedure. For this procedure, you do need neuromonitoring. So I start first by putting a Jamshidi. So we are starting the surgery now. Time it. We are putting a Jamshidi needle. I take first 5 cc of the bone marrow, not blood, bone marrow, because after 5 cc, whatever you take is blood. We have counted the number of the stem cell. After 5 to 7 cc, you drop like 90%. So it's more or less venous blood you're taking. But the first 5 cc had a lot of stem cells. So I mixed that with our biologic in a very specific protocol. We will share it all with you. And that gives the mode adherence of the stem cell to the particulate tricalcium phosphate in a collagen matrix. Now, what you see now is actually that the Jamshidi is in, the bone marrow is going to be taken out. And now the next step is actually pay attention as well to neuromonitoring window here. The next step is actually to put a and again, we don't use BOVI, we don't use bipolar, we don't use a suction device. We measure we have sponges, we use only sponges, we weigh them before and after. That's how we calculate our blood loss, which is usually about 45 cc per level. Usually, that's what it is. After 1,600 cases, only 3 patients have gotten blood transfusion, but those were patients that got a 4 or 5 level fusion. Some of them even with coagulopathy. As a matter of fact, those were not a candidate for open surgery at all. So here what you see is, I'm going to go maybe to show you, you saw the neuromonitoring probe going there, and now a K-wire went in. Over the K-wire, a dilator get entered. And here you see that over the dilator now, a tube, the Varun had much better pictures, it gets hammered in. And now, as you see, we are introducing the cannula, which is 8 millimeter inside, 10 millimeter outside. And now here you see that actually the actual dilator comes out. The drill goes in. If you remember in Chennai, I told you be very careful with this step. The drill creates a path, and then a series of very specialized tools go in and perform a discectomy. I think Varun can agree with me. If there is a disc you need to take out, you can take out with these specialized tools. And as you see here, now these tools are now in action. These are again very specialized tools that enable you to go through a 8 millimeter cannula and perform a discectomy. Now, at this point, I pack this space with tricalcium phosphate in a collagen matrix soaked with bone marrow, and you will see that space will go dark because it has a high density. Now, what's important is this material that I use, you see it went dark. After 12 minutes, it has the consistency of gel foam. As a matter of fact, some of the residents and fellows in Chennai, I ask you specifically if you remember to touch it. It has the consistency of gel foam, meaning that even though if you get a CAT scan, it may extrude out, it cannot provide pressure because it has the consistency of bone marrow, thrombin gel foam, but in the CT, it looked like bone because it's tricalcium phosphate. So you see another device, the loop cutter. Varun, I will help you to get that because that enables you to go 14 millimeter in each direction. My next present for you will be this one because that makes the life so much easier. And as well, the articulating correct. So I know what I'm bringing next time to India. This is one of my favorite tools. Practically what you have, you feel the high frequency vibration when the metal is on the bone. Then you know you have done a good job for the preparation of the end plate. And again, this is continuously running. You only need EMG. You don't really need SSCP or MEP. EMG and stimulation is what you practically use. Now, as you see, we go with the articulating rake up and down and prepare the end plates. And then the pituitary, long pituitary is very useful tool. And I saw how you're using it. I use it exactly the same way. You go to 4 quadrant, backhand, forehand, and perform practically the discectomy. At this point, you will see that we are going to put bone marrow with the tricalcium phosphate. Then we put a K-wire, then the tube comes out, and the next step is the cage is going in. Now, I'm not sure if you timed it or not, but can anybody tell me from the time I told it we are starting, how many minutes it has been? It's probably around 7 to 8 minutes. In 7 to 8 minutes now, the cage is going to go. Now, the cage, you go through the fascia, you just gently dilate it, you let it sit on the capsule and then gentle tap to make a divot in the capsule. But then, once you're there, I bend the K-wire and now a big, first, this is the gentle tap and then the big hammer, and then you just have to hammer it in. Don't play around at that point. And here you see, now here, there's a technique I will show you tomorrow more. I go at 90 degree in the wrong way, and then I turn it 90 degree to make it the correct way. Practically, we call it in situ rotation. We make a static cage to expandable cage. So if we go at the 9mm profile, and as you just saw, we turn it and it opens up the space. Then I don't have to deal with all the mechanism, small, tiny mechanism of expandable cage that half of the time they have failed in my hand. So the cage is in. As you see here, I'm packing the holes with the some sponges, and we measure them before and after, and we are looking at neuromonitoring. It is normal, right while you are going in, to get about 10 to 20 seconds of signal. That's normal. Then it slows down and it goes away. Warren explained that 3 milliamp when you go in, when you are in the Cambium triangle, 4 milliamp. So the cages are in, and as you see, two of the guide wires, the K wires are in and then I'm just have to put 2 more Jamshidis, 2 more K wires, and then pass a rod, and then we are done. So being able to do this surgery, literally from the beginning, you are seeing the surgery in actuality. This is not sped up, or this is not, we are not skipping any sequence of this surgery. This surgery was skin to skin in 25 minutes. And as Warren can say, Warren was saying half an hour. Well, yes, we spent another 5 minutes to close the skin, but more or less, you're seeing this surgery in actuality. So, and here again, putting the Jamshidi again, one of the things I think we observed that with 2 CRM, putting the Jamshidis in, it becomes so much more easy and more straightforward. And as you see here, the Jamshidis are in, the K-wires are in.
Sorry, you have to conclude. We are already late.
We are done with the time. So there's really not much to see here. The rest is putting the rod, and then we are done. Now, I'm going to answer a few questions, if you have few questions. But before we do that, as a token of my appreciation for Dr. KK, who really went over the board, and I'm so thankful to introduce me to your fantastic team. I saw that your team as well really appreciated that decortication device. So I have another of that for you and your team. I hope you guys in the next year put it to excellent use. Thank you so much again for everything you have done. Thank you. I appreciate that. Thank you.
Yeah, thank you, Dr. Abbasi and your team for excellent presentation for this Cambium triangle fusion and everything. It has a role in indicated cases that we have to look at for that one. Question with specialized instrumentation is required. Segmental lordosis, I think expandable case has its own role. And as Dr. Varun says, in indicated cases, this surgery has a role under local anesthesia, also in high risk patient and everything. Thank you very much.
No, thank you very much. It was great to be here. We are hoping really to be able to, with your help, to add this tool to the tool set of every surgeon, hopefully. Thank you very much. By the way, this is you don't see it anymore.
Thank you, Professor Abbasi. It has been an excellent session conducted, and there are less questions for you. The reason is that it has been taken by so many people in India positively that they all are starting to understand it in a good way. Thank you for coming here, Professor.